This presentation looks at the concept of protection related to OB. Protection is the primary and secondary defense mechanisms necessary to maintain homeostasis and responses to real or perceived injury or infection, including physical and psychological aspects of self-preservation, through the coordination efforts of the intact immune, skin, hepatic, and hematologic and renal systems. Here are your objectives for this presentation, so please look them over. Here are your exemplars and readings for the 11th edition. Then the following slide is for the 12th edition. All right, we're going to start with protection in the pregnant woman. So first is cervical insufficiency, also known as incompetent cervix. So the etiology of this is that we have a passive and painless dilation of the cervix without contractions due to a structural or functional defect of the cervix. It may be acquired or congenital. The risk factors for cervical insufficiency include multiple gestations, repetitive second trimester losses, previous preterm birth, progressively earlier births with each subsequent pregnancy, short labors, previous elective abortion or cervical manipulation, DES exposure, or other uterine anomalies. Diagnosis of cervical insufficiency. So this is a condition that is identified in retrospect, meaning after a woman has had several losses, typically in the first and second trimester, then they go back and say, hey, we might have cervical insufficiency. Then what they're going to do is they're going to measure cervical length as a way of diagnosing insufficiency. We're going to identify women who have cervical changes because of impaired cervical strength before conception or in early pregnancy, rather than when they are beginning the process of preterm labor. We can use a speculum digital pelvic exam, a transvaginal ultrasound. This can identify an abnormally short cervix, which would be a cervix that measures less than 25 millimeters. And we can also look for cervical funneling. As far as care for cervical insufficiency, the care of choice is going to be a cerclage. Okay. The cerclage is, again, treatment of choice for women with cervical insufficiency due to cervical weakness. They place a suture around the cervix beneath the mucosa to constrict the internal os of the cervix, okay, so to prevent that dilation. It can be done abdominally. A suture is placed at the junction of the lower uterine segment and the cervix. Now, this type is used for congenitally short or amputated cervix, cervical defects, a cervix that's previously scarred, or unhealed lacerations or subacute cervicitis. So keep in mind that cerclages could be either elective or emergent. An elective cerclage can be placed in the first trimester or early in the second trimester. It has an 80 to 90% success rate in preventing fetal loss and premature labor and birth. This can be done as an outpatient procedure. It can require hospitalization for approximately 24 to 48 hours. If it's an emergent cerclage, it's placed when dilation and effacement have already occurred. There's a 40 to 60% success rate, and these women are hospitalized from 5 to 7 days. Follow-up care. So a lot of practitioners still prescribe bed rest, but that has not been scientifically proven. Progesterone therapy may be recommended. And of course, the nurse is to watch and report signs of preterm labor, rupture of membranes, and infection. After 37 weeks, the suture may be cut and vaginal birth permitted, or they may decide to leave the suture in place so they don't have to place it again in the next pregnancy and perform a cesarean birth. Here's a picture of the open cerclage or the open cervix, excuse me, and then how we close it with the cerclage. Next, we're talking about placental adherence issues. Abnormal placental adherence to the uterus can be considered total, partial, or focal, depending on how much placental tissue is involved. The different types include placenta accreta. This is when the chorionic villi attach directly to the uterine myometrium. We have a slight penetration of the myometrium. It is associated with maternal hemorrhage and failed placental separation after birth. These women have a high incidence of abdominal hysterectomy. Placental increta, the myometrium is invaded, so we have deep penetration of the myometrium. Placenta percreta, the myometrium is penetrated along with the uterine serosa, possibly involving adjacent organs, such as the bladder. Risk factors for placental adherence issues are placenta previa, prior uterine surgery, endometrial defects, submucosal fibroids, multiparity, and older maternal age. Diagnosis can be done before birth with ultrasound and MRI. When the diagnosis is made prenatally, C-section is recommended. However, often these disorders are not recognized until there is excessive bleeding after birth. When there is adherence with a more extensive involvement, bleeding becomes profuse when removal of the placenta is attempted. Treatment includes blood transfusions. Hysterectomy can be indicated for all three types if bleeding is uncontrolled and is almost always required for placenta percreta and increta. These women are at risk for postpartum hemorrhage. All right, chorioamnionitis is a bacterial infection of the amniotic cavity. It's also referred to as amnionitis or an intrapartum infection. It's a major cause of complications for mothers and newborns at any gestational age. Most often, it occurs when after membranes rupture or labor begins, as organisms that are part of the normal vaginal flora ascend into the amniotic cavity. It's diagnosed by clinical findings seen in the mother, such as a maternal fever, maternal and fetal tachycardia, uterine tenderness, and purulent amniotic fluid with a foul odor. Risk factors for chorio include prolonged membrane rupture, multiple vaginal exams, use of internal fetal heart rate and contraction monitoring, young maternal age, low socioeconomic status, nulliparity, pre-existing infections of the lower genital tract. Maternal complications can include bacteremia, dysfunctional labor, which may result in a C-section, and if they do have a C-section, it is likely that a wound infection or a pelvic abscess are potential issues. Neonatal risks include pneumonia, bacteremia, meningitis. These infections can lead to death. Respiratory distress syndrome, periventricular leukomalacia, cerebral palsy, fetal infection that eventually produces a fetal inflammatory response syndrome, resulting in pulmonary and central nervous system damage. So treatment is going to include IV broad spectrum antibiotics and the birth of the fetus. So during labor, your mom should receive ampicillin, penicillin, or gentamicin. After birth, they're going to add clindamycin or metronidazole, which is Flagyl, to the regimen. Now, postpartum, the woman usually only requires one additional dose of ampicillin and gentamicin. Then we're looking at the preterm premature rupture of membranes. So this is a spontaneous rupture of membranes before the onset of labor, but also before 37 weeks gestation. Risk factors include infection, a previous history, hydramnios, multiple pregnancy, UTI, amniocentesis, placenta previa, abruptio placentae, trauma, incompetent cervix, bleeding during pregnancy, and maternal genital tract anomalies. Maternal complications associated with PPROM include infection, specifically chorioamnionitis, and endometriitis. Endometriitis is a postpartum infection of the endometrium. Abruptio placentae is another complication that does tend to occur more frequently in women with PPROM. Rare complications include a retained placenta with hemorrhage, maternal sepsis, and maternal death. Your fetal newborn complications, risk of respiratory distress syndrome, fetal sepsis, malpresentation, umbilical cord prolapse or compression, non-reassuring fetal heart rate tracings, premature birth, and increased perinatal morbidity and mortality. Nursing care for PROM and PPROM. First, we need to determine how long this woman has been ruptured. Okay, so if you remember, we are going to do this with the nitrazine test and looking at a sample of the fluid under the microscope for the Ferning pattern. Okay, so this is first going to confirm that yes, it is amniotic fluid, and then we're going to try to determine by mom's report how long she has been ruptured. We need to assess the gestational age of the fetus, of course. Monitor for infections, so we'll be looking at the white blood cell count, the temperature, heart rate, and the character of the fluid. Right? Of course, we'll be doing fetal heart rate monitoring. In PPROM, we do need mom to be hospitalized because she is so at risk for going into preterm labor. If she is preterm, and we know that delivery is imminent, then she will receive antenatal glucocorticoids. Okay. We want mom to maintain bed rest. We're going to limit our vaginal exams so we don't introduce infection. Providing comfort measures. Adequate hydration, encouraging that left lateral positioning for circulation, prophylactic antibiotics are possible for about 48 hours, and also educating our client. Uterine rupture. A uterine rupture is a rare but serious injury, of course. It's the symptomatic disruption and separation of the layers of the uterus or a previous scar. So risk factors include a prior uterine rupture, trauma, abortion, instrumentation injury or uterine perforation, Grand's multiparity, and uterine overdistension, such as macrosomia, multifetal gestations, polyhydramnios, or fetal male presentation. The most frequent cause of a uterine rupture during labor and birth is the separation of a scar of a previous classic cesarean birth or uterine trauma from accidents or from uterine surgery. So uterine rupture, of course, would be diagnosed in labor and delivery. What we're going to see is a category 2 or 3 fetal tracing, abrupt decrease in the fetal heart rate, late or variable decels, absent variability, tachycardia or bradycardia. The fetal parts or the fetus itself may be in the peritoneal cavity. There's a loss of fetal station, no fetal descent. Mom may experience a sudden sharp abdominal pain, a ripping or tearing sensation that's not related to the contractions, and bright red vaginal bleeding. So of course the best thing to do is going to be to prevent uterine rupture. So to do so, if we have a mom that has had a cesarean section or uterine surgery that has required a classical uterine scar, we will not allow her to go through a trial of labor or to VBAC. If we have a mom that is high risk, we are going to monitor her very closely, and we need to monitor for uterine tachysystole. If this is seen, we're going to decrease or stop the Pitocin, give your tocolytics to decrease the intensity of uterine contractions. Okay. Management of uterine rupture would include a laparotomy for repair, repairing lacerations, potentially blood transfusion, and hysterectomy. A hysterectomy could be done if the rupture is large and it's difficult to repair, or if the woman is not hemodynamically stable. Fetal prognosis is based on if placental abruption occurs and the degree of hemorrhage. Next is protection and the newborn. Okay, so looking at HIV/AIDS, we first have to start with how maternal-child transmission occurs. So it can occur through the placenta during pregnancy. More than likely and most often it occurs during that vaginal birth, and it can also pass through the breast milk. The majority of all infections believed to occur during labor and birth. However, we do have a decreased rate of transmission in certain women. These would be women that received prophylactic antiretroviral therapy during pregnancy. If they chose delivery by an elective cesarean at 38 weeks before the membranes ruptured, and those that completely avoid breastfeeding. Now, after birth, HIV infection in infants is diagnosed using the HIV virologic assays. Initiation of infant antiretroviral prophylaxis is done immediately if the test is positive. As far as newborn HIV/AIDS testing, the test is called the human immunodeficiency virus deoxyribonucleic acid nested polymerase chain reaction. It can take up to 28 days for definitive results from this test. Neonatal HIV and AIDS. So typically, your newborns are asymptomatic at birth. We do have what's called early onset HIV, which is within 48 hours of birth. This means that the baby was infected prenatally. These babies tend to develop opportunistic infections. The disease progresses rapidly, and death is common in the first 1 to 2 years of life. Others can take months or years to seroconvert. Most are symptomatic by age 1. However, it could take many, many years, 10 or so, to show symptoms. The later the child is symptomatic, the greater the positive outcome. For nursing care, we really want to bathe the baby immediately after birth to get rid of all the maternal fluids. Provide comfort for the baby, make sure the baby is well nourished. Try to protect the baby from infections and provide good skin care. Facilitate growth, development, and attachment. They will be treated prophylactically with AZT within 12 hours of life, and will take it for the first 6 weeks of life. Body fluids are potentially infectious, so standard precautions are observed. A quick review of the newborn's immune system. The newborn's immune system is developed prenatally. However, at birth, it does function sluggishly. The immune system isn't fully activated until well after birth. Okay? The newborn has poor hypothalamic response to pyrogens, so therefore a fever is not a reliable indicator of infection. In the newborn period, hypothermia is a more reliable indicator of infections. So if you remember, the baby does receive passive immunity from mom. It lasts for 4 weeks. What we get is passive acquired immunity during the 3rd trimester. And we know that the preterm infant who does not go through that 3rd trimester is obviously going to be more susceptible to infection. The newborn also has its own immunity. So the fetus produces IgM beginning at 10 to 15 weeks gestation. They start to produce IgA in the intestinal mucosa at 4 weeks. And of course, your breastfed newborns have passive immunity from mother through breast milk, through that colostrum. So sepsis neonatorum is a blood infection in infants that are younger than 90 days old. Early onset sepsis is seen in the first week of life. Late onset sepsis is between days 8 and 89. Nosocomial infections are possible if your baby is admitted, especially to the NICU, and has invasive procedures done. 2 most common for babies are MRSA and Candida. Again, it's related to invasive procedures and the fact that the immune system is immature. And Infections present themselves as sepsis, as UTIs, meningitis, or even pneumonia. Okay? So babies that show signs of infection or are admitted to NICU may have prophylactic cultures done. Okay, so we're going to take cultures before we start antibiotic therapy. The types of cultures that may be drawn, you have anaerobic and aerobic blood cultures, spinal fluid culture, urine, skin, and tracheal aspirate cultures. Potential tests that you may see drawn on your newborns looking for infection could be the CBC, the CRP, which looks for inflammation, a chest x-ray, a white blood cell count. Okay? A white blood cell count of 30 to 40,000 may be normal in the first 24 hours of life. 5,000 to 7,500 may indicate sepsis. Additionally, a low neutrophil count and high band count indicates infection. Signs and symptoms of sepsis include respiratory distress, lethargy or irritability, hypotonia, pallor, duskiness, or cyanosis, cool and clammy skin, temperature instability, meaning that it fluctuates, feeding intolerance, hyperbilirubinemia, and tachycardia that's followed by apnea and bradycardia. Nursing care of the septic newborn. We need to control the infant's environment. Okay, so that means they are in the isolette. We are monitoring and controlling who touches the infant and gets near the infant, what they're exposed to. We're maintaining a nice, warm, neutral environment. All right, we need to prevent the spread of infection, of course. So good hand hygiene, changing gloves, monitoring who touches the baby, that sort of thing. And our baby will also receive antibiotic treatment. So broad spectrum antibiotics are given before those septic workup results come back. So that's going to be your ampicillin and your gentamicin. Once we figure out what the pathogen is, then we will tailor our antibiotics. Typically, your newborns here are treated for 7 to 14 days. But if your cultures are negative and there's no symptoms, they will DC the antibiotics after 48 hours. Okay, supportive care includes maintaining their respiratory, cardiovascular, thermoregulation, and nutrition. Okay. Now, this is a difficult time for parents anytime that you have a child sick, but especially a newborn. But you do want to encourage your parents to interact with the baby and be involved in the care as much as they can be. Torch infections. So a torch infection is a group of perinatal infections that includes toxoplasmosis, rubella, cytomegalovirus, and herpes simplex virus. All right, so toxoplasmosis, this is contracted by eating raw or undercooked meat, especially pork, beef, lamb, and caribou. It can also be contracted by drinking unpasteurized goat's milk or contact with cat feces, whether changing a litter box or gardening. So a couple of things that we teach our patients: make sure to wash vegetables thoroughly, wear gloves when gardening, and it's time for someone else to change the litter box. Okay. Now, it does take cat waste 48 hours to become infectious. Okay. Fetal risks of toxoplasmosis, retinochoroiditis, which is an inflammation of the retina and the choroid of the eye. If there's a severe infection, they can die soon after birth. Survivors may be blind, deaf, and have severe intellectual disabilities. Other risks include convulsions, coma, microcephaly, and hydrocephalus. For treatment, we will treat the mom with spiramycin in the first and early second trimester. This medication must be retrieved from the CDC. Primethamine, sulfadiazine, and folinic acid in the late and second trimesters is also possible. The infected newborn is treated with the same 3 drugs. Next is rubella, or the German measles. Fetal risks include congenital cataracts, sensory neural deafness, congenital heart defects like a patent ductus arteriosus, mental retardation and cerebral palsy, and your positive newborns will need isolation precautions because this newborn is infectious. It will have an elevated rubella IgM antibody titer at birth. So for rubella, we can prevent. The vaccination is given prior to pregnancy or postpartum. So remember that it is a live virus, the MMR, so it cannot be given during pregnancy. A titer for mom of 1 to 10 or greater means that she's immune. And to prevent contracting rubella, stay away from crowds or any affected people. Cytomegalovirus belongs to the herpes virus group. Transmission is through the placenta or the cervical route during birth. It's found in all body fluids. It's contracted by a pregnant woman through exposure to a child's saliva or urine. So you can think about women that don't wash their hands after changing a diaper or wiping runny noses. We teach them to avoid sharing food, drink, or utensils with young children. Don't do it. Okay. Currently, there is no treatment for this type of CMV, but there is a vaccine in the works. Fetal risks associated with CMV include mental retardation, hearing loss, learning disabilities. Fetal death, microcephaly, hydrocephaly, and cerebral palsy are related to a maternal primary infection in the first half of pregnancy. Then, of course, you can have a baby that has no damage at all. All right, herpes is transmitted through an infected birth canal or an ascending virus once the rupture of membranes occurs. Vesicular lesions in the genital area or on the cervix. You may or may not be able to see them, but when the baby comes in contact with them on their way through the birth canal, that is how they are infected. We are going to try to prevent the transfer to the baby by treating mom with acyclovir, valacyclovir, or famciclovir during pregnancy. Remember that if mom has active lesions at the time of birth, then she will receive a cesarean section. Fetal risks of herpes infection include spontaneous abortion, low birth weight, preterm labor, and neonatal infection. So half of these newborns actually get the vesicular skin lesions. Neonatal symptoms include fever or hypothermia, jaundice, seizures, poor feeding. It can be seen anytime after birth up to 4 weeks. And if your newborns are positive for herpes, they will receive acyclovir. Right? Another very important infection that's not a part of TORCH is the group beta streptococcus, okay, or GBS. This is a bacterial infection in the vagina or rectum that exists in 10 to 30% of women. It's transmitted by the passage through the infected birth canal. So again, the baby goes through the birth canal and picks it up through the fluids. Now, screening is done, screening for GBS. We obtain cultures at 35 to 37 weeks gestation, both vaginally and rectally. Women that are GBS positive will receive antibiotics during labor. So she'll get penicillin or ampicillin. If there is an allergy to the cillins, then we can administer clindamycin or erythromycin. Okay? These antibiotics need to be given within 4 hours of birth to be effective. Okay? Fetal risks, whether it's early or late onset, your babies are at risk for long-term neurologic complications. If it's early onset, then they're at risk for respiratory distress or pneumonia, apnea, and shock, all within the first week of life. A late onset, they're at risk for meningitis or pneumonia, and this is 1 week or more after birth. And neonatal death. The virus can actually remain dormant for up to 3 months. And next, we talk about fetal alcohol syndrome. All right, so infants of substance abusing mothers, including alcohol, may suffer withdrawal. Okay, any teratogenic substances that are ingested could result in congenital anomalies and developmental problems. All right, so let's talk about alcohol dependence. Fetal alcohol syndrome is associated with preventable mental retardation. We do have alcohol-related birth defects and a neurodevelopmental disorder. Alcohol dependence is seen as physical dependence in the baby, and signs of withdrawal appear within 6 to 12 hours and at least within the first 3 days. All right, your newborns with fetal alcohol syndrome, they do have an abnormal structural development, central nervous system dysfunction, a growth deficiency, facial abnormalities, and associated anomalies of the heart, eyes, ears, kidneys, and skeleton. Symptoms of withdrawal in your babies with fetal alcohol syndrome include sleeplessness, excessive arousal states, inconsolable crying, abnormal reflexes, hyperactivity and jitteriness, abdominal distension, exaggerated mouthing behaviors, and seizures. Nursing interventions for babies with FAS, avoiding heat loss, providing adequate nutrition, reducing environmental stimuli, so we want a quiet, dimly lit environment. If at all possible, we want to provide consistency in the staff working with the baby. Parental support. They will definitely receive a social service referral. Typically, if the mother has been abusing alcohol, then there is a greater chance that she has abused other substances. So we will collect the baby's urine and meconium and test them for other types of drugs. Okay. We will administer medications as needed to help with the withdrawal process. Depending on the type of withdrawal, you may have a neonatal abstinence score to perform. We're going to monitor for hypothermia. We're going to monitor pulse and respirations every 15 minutes until they're stable. Provide small, frequent feedings to prevent vomiting. We're going to position right side lying or semi-Fowlers to avoid aspiration, especially in the case of vomiting. We're watching for other things that can happen with withdrawal, like diarrhea, vomiting, and we're going to weigh them every 8 hours. Okay? We do our best to provide comfort, so that means swaddling, non-nutritive sucking with pacifiers. Okay? If they do have diarrhea or vomiting, then we need to make sure that we're watching for excoriation. So protecting that face, the groin, and the buttocks from skin breakdown. Okay? Keep the surroundings quiet and dim. Do your best to reduce the withdrawal symptoms, so treat them symptomatically. Provide parents with support resources and provide ongoing evaluation for any long-term problems that they are at risk for.